Or disc repair on a patient who has two bad discs, herniated bulging discs in the lower back with back pain and left leg radicular symptoms. Now you've had back surgery before, right? And how long ago was that back surgery? 1993 in the military. We can see your scar here. And it actually helped with your leg pain for a while, right? Yeah. So he had pain down his leg years ago. They did a laminectomy, helped out. But now he's got bad back pain. And there really are very few things that actually can help with back pain. So the Deuk laser disc repair is going to be done today. We're going to treat his back pain and leg pain. All right. We're going to get started, okay? Are you comfortable? Yes. All right, so in the beginning, you're going to be awake. As you know, you've watched my surgeries before online. And then we're going to put you to sleep in about 5 or 10 minutes. Just depends on how quickly I can get to where we need to be. I need your help in the beginning, all right? If you feel pain, say ouch. If it goes down your leg, say ouch, down my leg, all right? The anesthesiologist will relay what you say to me because it's a little muffled for me to hear. All right, but just don't try to move around the table, okay? We're going to get started. This is my hand on your back, okay? So I'm going to feel around a little bit. Try to relax. So some patients are real anxious. They tighten up. It would be good, a little anxiolytic, but I don't think he's that anxious, but you can gauge it yourself. Yeah. All right, very good. I'm just kind of palpating around to find the right place to go. Okay, you're going to feel a little stick and a little bit of burning. That's just the medicine going in, okay? So when I first started doing these surgeries, I would map everything out because there's a way to map everything out. Luis remembers those days. But now I've gotten to the point where honestly I can just see where I need to go. And sometimes I need to make a course correction, but you need to do that even if you map everything out as well. Is that uncomfortable? No. You doing okay? Yeah, I know. That's just the numbing medicine going in. I apologize. 5 cc's injected. All right. Remember our deal. You're going to let me know if you're uncomfortable. How's our blood pressure? Good. Working on it? All right. I'll wait for a minute. All right. So the Deuk laser disc repair is an endoscopic surgery, endoscopic spine surgery. And we do the surgery in 3 different parts of the spine. Just keep your head down, okay? I'm just talking to the audience while we're waiting for the blood pressure to come down a little bit, okay? And we do the Deuk laser disc repair surgery on the cervical spine or the neck, the thoracic spine, and then the lumbar spine. And I've done over 1,300 procedures now. We've stopped counting. It's plenty enough to boast about and to verify my credentials and qualifications. But I've been doing endoscopic spine surgery now for almost 16 years here at Deuk Spine Institute in Florida. And endoscopic spine surgeons, there's not many of them in the United States, only a handful, maybe 20. And those are true endoscopic surgeons, ones that use a tiny endoscope and a tubular retractor, and they all do surgery on the lower back. None of them do it on the neck, cervical spine, and none of them do it on the thoracic spine. Okay? So we're the only place that does cervical, thoracic, and lumbar in the United States and probably the world. Nobody does thoracic endoscopic surgery. Not the type that we do, which is transforaminal. There are a couple of institutions like the Barrow Neurological Institution, where they do transthoracic endoscopic disc surgery. And that's very risky. You have to be in the hospital. They take your lung down to do the surgery, and there's high chance of complications. With our thoracic endoscopic surgery, we do it through a 4mm incision. You don't need to go to the hospital. It's all outpatient. And our success rate with thoracic disc herniations and thoracic pain is 100% in 10 patients. We've done 10 patients so far. And all 10 patients have had 100% elimination of the thoracic pain. That's the axial pain and the radicular symptoms going along the rib. All right, how are we doing on blood pressure?
160 down to 125.
Nice. You feeling all right? All right, I'm going to get started as long as we can keep moving in the right direction. We just need a little bit more than that, and I'll be very happy. All right, remember, if you feel discomfort, let me know, okay? And I'll give you some more numbing medicine. Just say ouch, okay? I'm going to give you some numbing medicine right now. You'll feel it. Okay. That's perfect. Yeah. Certainly acceptable. All right, so shot. Lateral. So I'm going to be talking to my team while we're doing this, and we're going to use an x-ray machine to basically navigate. We call it navigating, just like the old captains on the ships used to navigate under the stars at night. We're going to navigate to the right place on your spine, okay? All right, so we need to look at 5-1 first. It's a little blurry, but also I think we need to adjust the orbit a little bit. Now, if you're interested in doing endoscopic spine surgery, I recommend that you make sure you get your navigation, the fluoro, set up properly before you get started. I think we need to change the orbit a little bit more. Let's see what we got there. So right now I'm adjusting our fluoroscope. I think maybe the other way. Let's try the other way and see what we get. I think that's worse. And you got them flat on the table, Luis?
Yes, sir.
Now, sometimes patients have some scoliosis. All right, let's try some WAG. It's amazing, those 5-1 facets, huh? They're so, the joint looks swollen. All right. Well, on the WAG side, I think we're perfect. It's just impressive how swollen you have some swollen facet joints. So we may have to do a facet treatment on you. Not right now. We'll talk about it later, okay? We'll just see how your facets are doing after the surgery. You have, basically, it's inflammation and arthritis in your facet joints. And we have a treatment for that we use a needle to treat. That's the good news. Huh? Yeah, right? Yeah. Shot? You doing all right? Good. Shot? Everything's going well here from my standpoint. Shot? You feel any discomfort there?
A little bit.
Shot. That's your facet. We're right up against it. Is that where your pain is typically? Close? Yeah. Shot? Yeah. All right. Where do you feel that? In the back, not down your leg. Correct? Just relax. Everything's going well, Sean. All right, let's get an AP. You're doing fantastic. Blood pressure is good. But it's 116. Yeah, 116 should be fine. That's very nice. So what a lot of doctors don't understand how important blood pressure is in spine. Because if you get an intramuscular hematoma, it's going to cause pain for the patient for weeks and weeks until the hematoma is completely gone. So that'll be related to systolic blood pressure. Yeah. Yeah, but a lot of people don't understand that, you know, for some reason. What? Do you feel anything? Where? In your back or down your leg? Your back.
Not down your leg. Now it's coming down.
How far down your leg? The buttock? It's going to your butt. Not to your foot or toes or... Yeah. Yeah. All right, so let's wag to 4-5. Yeah, that's really good. I wouldn't go any lower. That looks pretty good right there. You're doing great, by the way, okay? Believe it or not, we're halfway done with the first part of the surgery where you have to be awake. So we're going to put you to sleep in a few minutes. Incision. So for those of you watching, did we put epi in the injection?
Oh, yeah.
We did.
Yes, sir.
So let's have that local again.
Yes, sir.
Did you take any anti-inflammatories?
No,
Fish oil, ginkgo biloba?
no, I quit last Wednesday when they called me and asked me if I could.
Yeah, that's fine. We're not having any significant bleeding, but you do have a little bit of what I call platelet ooze. But it could just be that we numbed a little further north, which is fine. It looks good. Are you comfortable?
Yeah.
All right, good. All right. So we've already accessed 5-1,
Okay.
which is the hard one. And, I mean, I should watch what I say because I don't want to jinx myself, but shot. But the good news is everything's going quite well. I'm very pleased. Yeah, we're not having any issues. Shot. So we're going to be putting him to sleep in about 5 minutes. Where do you feel that? In the back, okay. Back? The buttock? Just lay still. Don't bring your head up. You're fine. Just relax. Everything's going well, okay? I promise you. Shot? Yep. We're almost done. How many of my surgeries have you watched?
Over the
Shot.
last year, I actually saw the first one on Periscope.
Periscope?
Yeah.
All right. Very good. Sean, you hear that? Shot? Periscope.
I tried to watch both the lumbar ones.
Uh-huh.
I get to where you put the sleeve and you get the hammer out
Yep.
and then you start talking big words.
Shot. Yeah. Big words. I try to keep it simple for everybody. Huh?
I'm a very simple man.
I am too. Believe it or not.
Also, you get two things the laser.
Shot. AP. So we're either through the tear or we're lateral. And I felt a little bit of deflection from the facet. So we need our AP view to verify. Yeah, we're inside. We're inside. All right. So you've done a good job of helping me. Are you comfortable? All right. So my patients all like to have the video of their surgery done because they like to see kind of what happened, right? Now our endoscopic surgery here is virtually bloodless. We've lost a few drops of blood, about 1 milliliter at most. And we're getting ready to put you to sleep in a few minutes, okay? So we know that there are 2 discs that are damaged. He has herniations at these 2 discs. There's 1 disc right here. It's called the L5S1. And he's got a tear in the disc, in the annulus, and the jelly from the center is pushed out through that tear. And it's creating pain. Then there's a 2nd disc above it, the L45. And by the way, the head is up here, and the tail or bottom is here. You like that? All right, so both the L45 and the L5S1 discs have tears and what are called disc bulges or herniations. And a disc bulge is a herniation. This is L5S1, this is L45. And what I'm going to do now is we're going to do a little test, which you already know about, so I can't trick you, right? What do you think about Florida so far?
I love Florida. I spent a lot of time in Florida. I stayed up in Jacksonville.
What part of Florida have you been to?
I've been all over Florida. My mom and dad. Oh,
How bad is that on a scale of 1 to 10? Huh?
good 9.5.
It's what?
Good 9.5.
Yeah, we don't do halves. So it's a 10. Was that your typical pain?
Yeah, would it get back?
Is that where you typically get your pain? Maybe it's not that bad all the time, but is that where you typically get it?
It's either right there or down the butt.
Yeah, of course. Yeah, discograms are really good at identifying sources of axial pain, but not so much radicular pain. All right, so this L5S1 is a 10 over 10. All right? Is it better now?
Yeah.
Good. We're almost going to put you to sleep. Now, I didn't hear what you said about your favorite place in Florida. Did you say Deuk Spine Institute?
That the area more like but my mom and dad live in Port St. Lucie.
Who's the most famous person in Florida that you come to visit?
I think probably Dr. Deuk.
Oh, good, good. You gave me the right answer. All right. How bad is that on a scale of 1 to 10? Huh? 12? Is that where you typically get your pain? So I got some great news for you, sir. When you wake up from this surgery, that pain will be gone for the rest of your life, as long as you don't do something stupid, which you're not going to. Crazy, stupid. Just follow my instructions. No lifting over 25 pounds for 6 weeks. No bending over at the waist, and you'll do fine. So we just confirmed, and you can count from 1 to 100 out loud for me. Count from 1 to 100 out loud in Chinese. Can you go ahead and put them down? Yeah, right now. You're doing great. Keep going. When you wake up, the pain will be gone.
7, 8, 9, 10,
All right. So we did a discogram. It's called an evocative discogram. And what we did was we evoked his typical pain. And that's great news. Why? Because if I had done the discogram and there was no pain at all, then we would have to reconsider what we're doing. But the fact that we reproduced his typical pain during the discogram tells me that those 2 discs are the cause of his pain, because he told me that's his typical pain. And you could see one was a 12 out of 10 at 045, the other one was a 10 out of 10 at 05S1. You got those? 12 over 10, 45, 10 over 10, 51. So now we're going to get started with the real part of the operation. But I do want to draw your attention. Sean, let's pull up the x-ray again for a moment. If you look at the x-ray side view with the dye inside the disc, you can see that the dye is normally concentrated in the center like a cotton ball. But this dye is leaking out through tears in the disc. And those tears are called annular tears or fissures. And that is where his pain is coming from. And that's what I'm going to go repair right now. This is the only surgery in the world that repairs annular tears. We're the first to publish in the peer-reviewed journals about this surgery, the Deuk laser disc repair. We're the only ones that repair annular tears currently. All right, we're going to start at 5-1. I'm going to use my x-ray to make sure that we don't take the guide wire out. We leave the guide wire. Sean? Now our patient is asleep. Now I'm going to stimulate him in about 2 minutes, because I'm going to pass through that tear with, you're pulsing, correct? Yes, sir. Yeah. We're going to stimulate him shortly, but he seems to be okay. Yeah. All right. So we've got our guide wire. We're going to come down with the dilator. And the dilator is about 5.5 millimeters, maybe close to 6. And the dilator is doing something very special. It's not cutting any tissues, okay? And normally in spine surgery, the spine surgeon is cutting. You guys see this incision here? Let's have that marker.
Yes, we do.
The incision from his old surgery to fix a disc is this long. from here to here. That's a massive incision just to fix one disc. And that was when he was in the Navy. That's called a microdiscectomy. Big incision, lots of scar tissue. And honestly, microdiscectomies do nothing for back pain. They can help leg symptoms. That's what surgeons target, are leg symptoms. Call it radiculopathy or sciatica or claudication. But for back pain, microdiscectomies don't work. Laminectomies don't work. Okay? But the Deuk laser disc repair works. It's really the only surgery that actually gives a permanent cure, because we're targeting the source of pain. All right, you can see on the, yeah, we'll get that out of there. Shot. You can see on the lateral x-ray that we're right at the disc, right at the tear. And I'm going to go ahead and advance my dilator into the L5S1 disc. Now be aware, if you do this kind of surgery, that this particular maneuver is going to push the herniation, usually push the herniation back into the disc. So it actually helps the surgeon, because now I don't have to deal with a disc herniation out in the foramen where the nerve root is. Shot? That's beautiful. So he's nice and relaxed. Our anesthesiologist has done a phenomenal job, because if the patient's in pain while I do this, then they tighten up their back muscles, and it makes it really hard to get inside the disc. So because the back muscles compress the bones down together at the level of the disc. That's what caused the herniation in the first place, was basically a load onto the bones that compress the disc. All right, so we're done with the dilator. Now I'm going to bring my final tubular retractor over the dilator. Shot. Beautiful. We use our lateral view to do that. Shot. Nice. Now we've got, see that the dilator move forward a little bit with the tube? It's cold welded together. We call it cold welding. That's where two pieces of metal that are separate start to move together, because they have a piece of tissue between them usually. And that's just a piece of the disc material. All right, we got our tubular retractor in, and we are ready to go. So, any questions about what we've done so far, Sean, from our audience?
No questions currently.
Deuk Spine Institute is the only facility in the world that broadcasts spine surgery live every week that we do surgery. The entire surgery unedited. So sure, there are a few live surgeries available out there, but it's rare that spine surgeons broadcast, and most of the time it's always edited. They want to cut out the parts that they don't want you to see. We broadcast the entire surgery. Why? Because we believe in transparency and honesty, and we believe in the technology that we're doing. It works, and we want you to see the whole thing. We want you to see we're not cutting sections out and modifying and making it look better than it really is. This is the real deal. We do it every week, and it works. This patient's back pain will be gone as a result of the surgery for the rest of his life. This is not a temporary cure. It's a permanent cure. Beautiful. All right. So now we are inside the tube. Let me take you down the tube, okay? So we're going to start at the outside where I am and the team is, and we're going to go down this metal tube. You can see the walls as we slide down. This is kind of like, what is that cartoon or that program? Alice in Wonderland. I like that, all right? I was thinking about that lost family that goes down on a raft. You know what I'm talking about? This old program. The Lost World or something like that. Sean? Huh? Land of the Lost. That's it. So we went down a cave on a raft here because there's water involved. The water you're seeing is the irrigation. And we use irrigation to flush things out and to keep the laser cool. This laser is so hot it will melt steel. But you have to keep it cool, so we use cooling irrigation. Thank you, Luis. All right, we're going to bring our laser in, and you're going to see it in just a moment. Now, what you're seeing, by the way, right here is the disc. That is the annular tear we're looking at, the white stuff, okay? That's what was torn years ago, and it's never healed. It's tried to heal for all these years, It's been trying to heal, but it's been unsuccessful at healing. And the reason it's been unsuccessful at healing is because of the interposed nuclear material, the blue stuff, that cannot get out of the way on its own. So we're going to remove the blue stuff with our laser. And it seems a little blurry for some reason, Luis. All right, so now we call this, you know, the technical term in medicine is called tissue modulation. We're modifying the tissues. These are the patient's normal tissues, the annulus fibrosus, the nucleus pulposus. The problem is the nucleus pulposus is out of place, okay? So if you have a compound fracture from trauma and you have a piece of bone sticking out of your skin through your muscle and skin, that's a problem. You have normal tissue, you got bone, skin, and muscle. Those are all normal tissues. However, things are out of place. You got to fix it. If you don't put that bone back inside and fix the compound fracture, it's going to create all kinds of problems, mostly inflammation and, of course, deformity. So that's what we've got here. We've got a piece of the body that's normally found inside the body, which is the nucleus pulposus, but it's found inside the annulus fibrosus. And through a series of steps, which we're going to be elucidating, we've already elucidated, we're going to be publishing this soon for you guys to see. The nuclear material has herniated out through the annular tear, which we've all understood for years. That's nothing earth-shattering that we've discovered. But what is really interesting is that the disc cannot heal itself as long as the herniation of the nuclear material is there. The annulus will not heal. And we need the annulus to heal to get rid of the pain. It is actually the pain that people have, chronic neck and back pain, comes from an annulus that's not able to heal. It's the inflammation within the annulus. The problem is that you won't find anybody talking about that because they don't know about it. This is sort of a new discovery. And we discovered it at Deuk Spine because we started to repair these herniations and the annulus, and patients' pain went away. So you just put two and two together. It wasn't long before we figured out the mechanism of action and the pathophysiology of back pain and neck pain and thoracic pain. Has to do with the annular tear. The reason other doctors don't realize the annular tear is the source of pain is because everyone's brought up to believe the annulus has no blood supply and no nerve fibers. And that is true for a normal disc, but it is not true for a herniated disc. And that's where everyone falls short in understanding this pathophysiology. All right, so I don't know why it still appears to be somewhat blurry to me, Luis. Any idea? Do you think these lenses are knocked out of place a little bit, or?
I don't think it's a problem with the laser, sir. I mean, I have
The
been
scope?
checking all them.
The scope, you mean?
It's like the emissary of the scope, yeah.
All right. Well, I mean, I can certainly see what I'm doing. So there's your annular tear right there. That's what we're here to fix. By fixing this, this pain will go away. Now, where do you normally work, doctor?
Las Vegas?
Wait. You flew from Las Vegas to work with me? I'm kidding. I know that's not true. Wow. So when did you move? Stand by. Good for you. And where did you move to?
Port Orange.
So about an hour away? Why Port Orange? Family there?
Yeah, it's for my brother-in-law. He's a gastroenterologist, and we're just raising our families together, you know.
That's awesome. I'm so happy for you. So you do his anesthesia cases?
Time to time.
Wait, gastroenterology. So he just does colonoscopies, EG.
Mostly I do Las Vegas, you know, maybe a week and a week,
Oh, so
2 weeks a month.
you fly back.
And then I don't work otherwise, and I'll do like little request kits like this.
I see.
I get along.
What's a request case? You work for that company that we hired or not?
I'm
Or-
independent, no.
Oh, you're independent.
But I mean, they got it for me. They asked me to do it, yeah.
So we had an anesthesiologist, have had, and she's out on medical, and it's been a long time. And anyway, I don't want to discuss the details, obviously, but we're happy you're here.
Yeah,
And I think we have more work for you if you're interested. I don't know if it's too much of a drive or what, but
That's not bad.
all right, so these are little fragments of herniation, like that one right there, and it's just floating out. Back to work on the annular tear. So have you ever done pain management?
Some, but I'm
Just
not
like epidurals and
trained, no, I'm not.
no. So you lived in Vegas for years. Did you grow up there or?
I grew up 3 hours away in the desert called Apple Valley, Victorville.
Yeah.
The high desert.
Yeah. I'm actually from California.
Yeah, I was born in Santa Clara. I moved down to Victorville area.
Nice.
Was raised in a really small road dirt bike.
You rode dirt bikes.
Oh yeah.
Oh, nice.
I raced professionally before medical.
You're kidding me. Race dirt bikes. Wow. My son is a professional race car driver.
Really?
He's 16. He's the #1 driver in the United States.
Get out of here.
Oh, he's a national champion.
Yeah, I've worked with some of that. I've worked with Gordon, Robbie Gordon.
Don't know him.
Rode bicycles with Jimmy Johnson the other day.
Oh, yeah. Yeah, Arias is an open wheel driver. He wants to go to Formula One.
Really?
Yeah. Formula One or probably IndyCar if we stay in the States. Maybe some NASCAR. He's already got offers.
Oh man. Paul, yeah, you guys must know Paul Tracy then.
No, I don't know a lot of people in the.
IndyCar champ for 8 or 9 years.
Huh.
Good friend of his.
Well, remember, my son is young, so we just started getting into it in the last couple of years. He's been in go-karts since he was 7, and
Got a knack for it, huh?
now he's moving up to cars. Just this year is his first year in cars, so he's doing Formula 4. We're going to be racing in Mid-Ohio in a few weeks. He's already raced at Road America and Road Atlanta.
Okay.
Those are the first 2 race weekends.
I understand the level.
Yeah, the level of commitment. He loves racing.
What
Yeah.
I did though, I was 19 and broke my tibial plateau really bad and all that.
When you were 19?
Yeah, and then had a ride from Yamaha and all that.
Wow. When did you start riding?
I was
7?
7.
So same as my kid.
Really, yeah, I was moved up really fast from California and all that.
That's awesome. You ever race Sonoma or Laguna Seca?
I raced Laguna Seca.
So you did dirt bikes. I mean, obviously,
We had a race at Laguna Seca one time.
yeah,
There in the hills, they put us on.
yeah. But were you one of those jumpers, like you watch on TV?
I raced Supercross, yeah.
Yeah, that's amazing. Yeah, that's awesome. It's so entertaining.
Stunt jumping stuff? No, that doesn't really interest me. I mean, it's crazy. It's fun
Yeah.
to watch, but it's incredibly.
Well, the way you guys race, though, it seems like you'd be good at jumps and tricks and stuff like that. You got so much air time.
Yeah.
You know, you got to be able to control the bike so well.
I can pancake a bike.
It's awesome. Still? Wow. So you still ride?
Time to time, just for fitness. I don't race.
Yeah.
Just go out there and do my laps. And, I can do all the jumps and stay. It's like just staying within. It looks like I'm going really fast, but I'm really controlled. I don't go beyond that.
Yeah, that's the key.
Do it for fitness.
That's the key right there. Is I always tell my kids stay in control whenever they're doing something, skiing, for example, snowboarding. That's the key, is to stay in control. But people don't understand what that means. It means you got to be able to turn or stop when you want to. Yeah, it takes time, a lot of seat
I
time.
feel myself like getting shaky or whatever, I stop.
Yeah. All right, so we got epidural fat here at 12 o'clock, and this is the end of the disc, basically. Remember, we're at L5S1. We're going to go to L45 next. We got about 2 minutes left on this disc, and then we'll go to the next disc. There's a little bit of epidural vein blood. That's what obscuring the view. Sean, any questions from our audience?
Yes, we did have one that just came in.
All right, give me 1 second. All right, if you look to the left at 9 o'clock, that's the end plate of L5. And then on the right side at 3 o'clock will be the end plate of S1. And I just want to say something for those of you who don't know, the laser is that little glass tip that's moving up and down. And then there's a blue fiber, which is the plastic covering over the laser fiber. The laser energy coming out of the tip of this glass thing, it gets out about 0.5 millimeter. So it can't like shoot around like in Star Wars and kill people. Though we don't want to try it and find out. But the energy really disperses past its useful point once it gets about 0.5 millimeter past the tip. So really the way you can vaporize tissue here with the laser is by touching it while the laser's on. So you got to make contact. If you don't contact the tissue, it's not going to vaporize it. The highest amount of energy is delivered right at the surface of the glass fiber. So that gives me tremendous amount of control over what tissues I'm modulating. Okay, remember we learned the word modulation. It means basically changing. And it's really a delivery of laser energy into the tissues that causes a disruption of what are called covalent bonds between molecules, and it allows the fragmentation of larger substances like big chunks of herniation or annulus. So there's a little vein right there. You can see it bleeding. Usually the laser is pretty good at stopping that. We can't put gel foam or thrombin down here, obviously. When I first started doing these 16 years ago, we did have some patients where I would have a little bit more bleeding than you're seeing here. And I tried putting thrombin down the tube to stop it. And of course, everything went fine because the bleeding stopped. It was going to stop on its own, but I didn't know that at the time. So I was freaking out a little bit. But now, given all the experience I have of doing these surgeries, I do an average of 2 discs per patient. So if I've done 1,300 plus cases, I've done really 2,600 discs. So that's a lot of disc repairs that I've done in 15 years. And the number is going up because people don't want fusions and metal in their back. They don't want artificial discs. They want a natural repair of the disc. And that's what we offer here at Deuk Spine Institute with the surgery. Some people make the mistake of thinking that Dr. Deukmajian only does this surgery because he doesn't know how to do fusions or artificial discs. I've done thousands and thousands of fusions, and I do, honestly, a better fusion than anyone else out there. Based on my outcomes, based on patient outcomes, relief of back pain, neck pain, whatever I'm fusing, arm or leg pain, generally in the 100% relief arena, and my lack of complications and my rapid recovery of my patients. So I do know how to do fusions very well. I used to do them all the time, but I've switched mostly to laser surgery because it's so much better than a fusion. All right, Sean, we'll take your question from the audience.
Yes, we have a couple. The first one comes from a viewer on Facebook who says, "Good morning. I've had back pain most of my life. My previous surgery was a fusion from L3 down to L5. Can you still help me? I still have pain in my hips and legs."
So one of our viewers from what, Facebook, Periscope?
Facebook.
From Facebook. Thank you for typing in your question this morning. Welcome to our live stream. Yes, you can be helped 100%. How do I know that? Because all these years of treating back pain has taught me one thing, that everybody's back pain comes from a specific structure, anatomical structure. And we have solutions for every cause of back pain, no matter what it is. Fusion generally will fix back pain. If it's done properly, it'll fix back pain that comes from a bad disc or a facet joint. It will not fix back pain that comes from the piriformis muscles or the sacroiliac joint. Those are additional structures near the spine that are also in the back that could be the cause of your pain. So we can definitely help you here at Deuk Spine, even though you've had fusion done already. We just need to set up a video conference with you where I can look at your back and I can see where your pain is. If I had to guess, if your pain is down by your butt crack, to the side of your butt crack, either left or right or both sides, it's your sacroiliac joint. but I can't guess, okay? I need more information because you could also have other problems like a fracture or a loose screw or an infection. There's a lot of things that cause back pain. And so I need to eliminate other causes that are potentially harmful to you and dangerous before we go assuming what it is, okay? And that's true for everybody, by the way. Great question. Thanks for asking. All right, we're pretty much done here at 5-1, and we should be able to see the L5 nerve root, but it's surrounded by fat. So we're pretty much done at this level. We've done our repair of the disc, and now we're going to pull out, and we're going to move on to L4-5, and then we'll be done with L4-5 shortly as well. Now we do have a treat today. We have a posterior cervical laminectomy infusion on a patient who has spinal stenosis at multiple levels in their neck. They've had a fusion done in the past. It didn't work. It failed, so they have a pseudoarthrosis. And they have herniated discs at multiple levels from C4 down to T2. And we're going to fuse from C4 to T2. All right, we're pretty much done here. You can see the tear. We've debrided it. That's the annular debridement, only done with the Deuk laser disc repair. This surgery is 100% FDA approved, peer reviewed and published numerous times. Very safe. We've never had a complication. Standby laser. All right, we're done. We're gonna just suck out all the juice, scope off.
Lights on, please.
All right, so we're gonna take our tube out. And what's the next question there, Sean?
Let's see here. The next question comes from another viewer on Facebook who's wondering, how can you treat degenerative disc disease? I have several discs in my lower back that are very degenerated and causing me lower back pain.
Yes, great question. So one of our viewers is saying, can you treat degenerative disc disease causing back pain? The answer is 100% yes. And we would treat it with this surgery right here, the Deuk laser disc repair. As a matter of fact, Sean, if you want to go back to this patient's MRI, you can show them this patient has degenerative disc disease at L4-5, L5-S1. And that's what we're treating right now with the laser surgery. Now, degenerative disc disease is just a term, and it doesn't really tell you how degenerated the disc is, because it could be at the beginning of being degenerated or it could be at the end stage of being degenerated. And really that has to do with how much the disc has collapsed and some other things that change, like loss of the nucleus and annular changes and then end plate changes. I don't want to get too technical, but basically it doesn't matter how degenerated the discs are. They can be repaired, and the back pain will go away with the Deuk laser disc repair, what you're watching right now. This patient has degenerative disc disease, and we're fixing it with the surgery. Another option would be to clean out all the degenerative discs that are symptomatic, put in cages and screws and rods. But you don't want that. That's a really unnecessary, very painful and high-risk surgery. So this is the way to go. This is really the only surgery that will cure that pain, besides a good fusion. Okay, is that where we are right there? All right, I'd like to see the sacrum a little bit. I think you're a little too high. Let me have it. Shot? Yeah, that's better. All right, you can see the guide wires there. We've already done the L5-S1 disc that was 10 out of 10 pain. Now we're going to the L4-5 disc. I got to make sure the guide wire stays where it is. Shot? Do you have another question for us, Sean, from the audience?
Yes, we do. We have a viewer from YouTube who is wondering, I have C4-5, C5-6 disc herniations. Do I have to go through a surgery called ACDF, or is there another option?
Yeah, great question. So one of our patients has C4-5, C5-6 disc herniations. you do not have to have a fusion. ACDF is anterior cervical discectomy and fusion. It's a surgical procedure that takes those discs out completely and replaces them with a piece of bone or a piece of metal or a piece of, it's really called carbon, polyether ether ketone, or PEEK. But basically, the discs are taken out and replaced with a what's called a biomechanical device or bone graft. You don't want that surgery, promise me. I promise you. I've done over 1,000 ACDF surgeries in my career of 26 years. And that is, this laser surgery we're doing right now, the endoscopic Deuk laser disc repair, can repair those herniated discs with a 4mm incision. And no fusion, no metal, no biologics. Basically, we would make a cut on your neck this big. I'll show it to you in a second. You see that right there? It's 4mm. And I could fix both discs with one incision, 4mm, by repairing the herniation rather than taking the disc out and fusing the bones together. But nobody else knows how to do that surgery but me here at Duke Spine Institute. So you're going to have to travel here to get it done. That's the downside. I can't fix you through the internet or television or telephone. It has to be done in person. So when you're ready, you just let us know. We have a free MRI review service. We'll look at your MRI and we'll meet with you over the internet through telemedicine, Skype, and we can talk about fixing your herniated disc without fusion. But stay away from fusion, stay away from artificial discs. Okay, so we are moving on to the second herniated disc, degenerated disc at L45. And this disc, remember when we tested it with the discogram a few minutes ago, it was a 12 out of 10. How's he doing? Is he okay? Yeah, good. Yeah, you can bring his pressures up a little if you want. All right. So, we're going to repair the next disc, and then we'll be out of here in about 15 minutes. I could feel the herniation. You can see the tip of the dilator is moving through the neuroforamen. When we do the cervical ones, by the way, we go through the front, in case you're wondering and interested. We don't go through the back. That would be really bad, actually. You would damage the spinal cord. We don't want to do that. So everything in the cervical spine is done anteriorly.
We have another couple questions.
By the way, for the person who asked the question about the ACDF, the only reason the surgeon is offering an ACDF is they don't know how to do the endoscopic surgery we do. That's the God's honest truth. So if they knew how to do this endoscopic surgery on the neck like we do, they would be doing it endoscopically. But the problem is all these surgeons have been trained on an old technology called fusion. And even artificial discs are an old technology. Artificial discs have been put in Europe now for 50 years. The United States, we've been putting them in for about 20 years. And but we were about 20 to 30 years behind Europe in artificial disc technology. So fusion is really old technology. Artificial discs are really old technology. Endoscopic spine surgery is the newest and best technology. That's what you're watching right now. And with endoscopic surgery, there's no metal, no plastic, no cadaver bone or bone graft put in you, okay? Here's the problem, folks. You're not going to see this surgery and hear about it from your surgeon because the surgeons make a lot more money with fusions, and the companies that sell the screws and rods for fusions promote them and market it so heavily, especially at the university level where all the training is done. So surgeons are basically trained, spine surgeons are trained to do fusions and promoted by these big companies that make billions of dollars a year on putting metal in you. Well, when I learned about endoscopic spine surgery and I went overseas to learn how to do it from the Koreans, I saw, my God, this works, and you don't need to put any metal in people or plastic in people. This, I got to bring this back to the States, and I got to start doing it. And unfortunately, there's only a few of us that know how to do this kind of surgery. So I think in the future, fast forward 20, 30 years from now, fusions will be a thing of the past. It's just like, can you imagine fusing your hip if you have hip pain? No one would do a hip fusion. It's just rare. Everything is done with artificial joints or endoscopically, like endoscopic knee surgery. Okay? So other areas of the body have advanced past metal implants and fusing. Spine surgery is advancing as well, but you're seeing the very beginning of it in the United States, unfortunately. So this is a new technology, and that's why we broadcast. We want everyone to know about it so that they don't have to undergo fusions. You know, your doctor may only offer you a fusion because that's all they know how to do. Unfortunately, when I finished my training, it was 17 years ago. Okay, 17 years ago I finished my training, and fusions of the spine were just starting to go on the rise. Well, what are called instrument infusions. They were just ramping up. Now they're in full swing. And all these residents that are training in neurosurgery and orthopedic spine surgery, they're coming out and they're learning fusion as the latest technology. Well, we've been doing endoscopic surgery now I've been doing it for 16 years. Fusion is not the latest technology. Artificial discs are not the latest technology. They're old technology. But unfortunately, the patients out there suffering with spine disorders that need surgery, they're not being offered endoscopic surgery, the Deuk laser disc repair like we're doing for this one, because they don't know about it. And their doctors don't know how to do it. Their doctors probably aren't going to send you to me because they want to keep the business. They don't want you going somewhere else. They only make money when you do surgery with them, and the only surgery they know how to do is fusion. So they're going to tell you fusion. That's why we broadcast, because we want people to know the truth. You don't need to have a fusion just because your surgeon only knows how to do a fusion. You don't need to have an artificial disc just because your surgeon only knows how to do artificial disc and fusion. Here at Deuk Spine, we can do artificial discs, we could do fusions, we could do any procedure in the spine. We've even taken tumors out of the spine. All right? So we've done everything here. Complex spinal reconstructions. We're going to do a complex spinal reconstruction as our next case. So if you come back and watch the next surgery today, you're going to see one of the most complicated spinal reconstruction and fusion surgeries that is done today in the modern world. And we're going to do it outpatient. We're going to send that patient home 2 hours after their surgery. Okay? And we've been doing it now for 8 years. It's called the posterior cervical decompressive laminectomy and instrument infusion with reconstruction. Okay, PCDF is the abbreviated term, and we've been doing them now for 8 years here at the surgery center with 0 complications, and everybody goes home within a couple of hours. Now, there's no other spine surgeon in the world that can do this surgery coming up and send the patient home the same day. We're the first to do it. We did it 8 years ago. And we're the only ones doing that surgery outpatient. Orthopedic surgeons really, for the most part, don't even know how to do that kind of surgery. It's really the realm of neurosurgeons, which I am a neurosurgeon. So you're going to see a real special surgery next. And the reason we're doing that kind of surgery versus a laser surgery is the patient has a lot of problems that can't be fixed with the laser. Most importantly, he had another surgeon who tried to do a fusion, an ACDF fusion, and the fusion failed. And now his screws are loose, and the plate is loose. So I'm going to have to stabilize everything through the next surgery, going through the back of the neck. So for the person that asked the question about ACDF, this next patient we're going to do in about an hour and a half, is a patient who had an ACDF 2 levels that failed. Didn't fuse. Happens all the time, folks. I see catastrophe fusion surgeries from other doctors. They come here to get fixed by me. And we can fix them, but unfortunately I can't fix that patient with the laser. It's too late for the laser. They had the fusion already done. These are pieces of herniated disc right here. And we usually try to float them out so I don't have to put the grabber in because it takes time. But you'll see I'm freeing them up because they're stuck to the annular tear. Oh my gosh, don't do it. How dare you? I'm kidding. Yeah, we're good. Thank you. This is all, by the way, what you're looking at here is all herniated interposed nuclear material that's caused inflammation in the annular tear, and it's thick, this thick stuff right here. I think we got a little bit overexposed. Can we bring the lighting down just a notch, one notch? Just bring the brightness down one notch.
We have a couple
Thanks.
more questions.
Yeah, I'll get to it in a second, Sean. I'll get to the questions in a second. But right here is, look at that thick scar tissue right there. This is all from chronic inflammation. Remember, inflammation is one of your body's defense systems, all right? If you think about inflammation, it's like the Marines or the Army, okay? Please don't, take offense. But let's just say it's like ground troops, okay? They're one of the first in the battle, all right, against an invader. And then, of course, you have the immune system, the other arm of defense. It's called humoral-mediated defense. And the immune system doesn't really care so much about these herniated discs as much as the inflammatory system cares. And the inflammatory system, when it sees a tear with a herniation of nuclear material, even a bulging disc, okay? And this is why most doctors don't understand this disease and can't help you. It's because they don't understand what's called the pathophysiology, the mechanism of disease and how it works. You can't fix a disease you don't understand the mechanism. Think about the bubonic plague. How many millions of people were wiped out by a tiny little Yersinia pestis, right? It's a little microorganism. Basically, I think it's a bacteria. And that bacteria was being transmitted from person to person, and it was killing people. And they didn't understand why. And of course, you can't stop something you don't understand. You can't understand how to treat it. It just needed antibiotics. Nowadays, nobody dies from the bubonic plague because once we see a bubo, we start them on the right antibiotics, which you could get for like $1 at the store. Point is, back then it decimated the rich, the poor, millions of people died when you could have just given them basically an antibiotic that is everywhere nowadays. So the point is, doctors don't understand why back pain and neck pain and thoracic pain occurs from a herniated disc, but it does. And this is how. It's inflammation. It's your inflammatory system attacking this nucleus pulposus that's herniated. All right, what's the question?
So our next question comes from a viewer on Facebook again, who asks, how long of a recovery time after the surgery, and will this person be able to do the physical activities that they were doing before the surgery, or are there any lifelong limitations?
Yeah, great question. So let's break it down. How long is the recovery for this surgery? It is literally 1 hour. All right. Now, in 1 hour, this patient will be walking. He could be driving, but we're not going to let him drive because he just had anesthesia. But he could go back to a normal life in 1 hour. As a matter of fact, we've had patients that have this surgery and then go back to their job the same day. And the reason for that is it's so minimally invasive, and the anesthesia that's given, the propofol, wears off so completely and beautifully and doesn't give patients that groggy, crappy feeling that you get from normal general anesthesia or other types of sedatives like, the benzodiazepines. So this propofol is like magic. It literally shuts your brain down for the surgery and then, or whatever procedure. And then when they turn it off, you wake up within 20 minutes. It's just out of your system. It's metabolized so quickly, and patients feel amazing. I mean, I've had it for my colonoscopies, right? Sorry to share that, but I mean, I go to get my colonoscopy done, and I'm back to work by lunch, Don't tell anybody that, but no, but in all reality, you feel like $1 million right after a few hours later. So the recovery is literally 1 hour for this surgery, 1 hour. Compare that to a fusion, which would be an alternative surgery for this patient, where the recovery would be 2 months of taking, dope, taking opioids, morphine at home, oxycodone, laying in bed, being in severe pain from the surgery itself, from that big incision and the muscle dissection. Okay? So, dramatic difference. If you have to choose between a fusion surgery or laser, this Deuk laser disc repair, this is the way to go. You get the fastest recovery. All right, now, is this patient going to have lifelong restrictions? The answer is 100% no. Okay? It takes 1 year to fully heal from the surgery. And the reason it takes a year is that this disc that I'm repairing right now, it doesn't have much blood supply. Look, I'm chopping it up, and there's really not much bleeding, right? And the reason there's not much bleeding, it doesn't have any blood supply. So the disc itself takes a long time to heal, and I can't speed that up. There's no way to speed that up. The disc itself just takes a year to fully heal. So patients recover very quickly with the surgery in an hour. They can go back to work, they can go back to driving, but you're going to have some bending and lifting restrictions that last until your disc is healed. So I don't want my patients lifting more than 25 pounds for the first 6 weeks. So if you're traveling from another country, don't bring a heavy suitcase. And if you do, bring somebody with you that can lift it. And then, of course, no bending at the waist if you're having your back done for 6 weeks. I don't want you bending over, picking things up. I've had patients re-herniate their disc, and the re-herniation rate with my surgery here, this surgery is about 1%. 1 in 100 will re-herniate right where I fixed them. And they'll be symptomatic from it, okay? So they get a recurrent disc herniation and symptoms that need treatment with surgery. So the reoperation rate is 1%. That means 1% of my patients that have this will end up re-herniating. Now, most of the time, they tell me, oh yeah, I know when it happened. I was lifting a suitcase at the airport. Or, how much was the suitcase? 50 pounds. Or they go to physical therapy and the therapist bends their legs up to their face while they're on a table stretching. Well, that's the same as bending at your waist. And then they feel a pop in their back. And there's a herniation, okay? So you can re-injure your disc after the surgery, and you'll have to have another surgery, period, to fix it. So I just tell everybody, take it easy for a year, let it heal properly, and then you can do whatever you want. You could even do motocross. You could take a motorcycle out and race it and jump, and you can do anything you want, honestly, after a year. Now the disc itself will heal, and it heals with collagen, usually type 1 collagen, which is mostly scar tissue, some elastin, some type 2, type 3, type 4. There's so many types of collagen, but it's going to heal with collagen. And the annulus fibrosus, the part that's healing with collagen, is actually naturally made from collagen. So it's actually healing with what it's naturally made from, which is the most perfect type of healing you can imagine. All right. Other questions? We got 2 minutes left. Doctor, just 2 minutes. Any other questions, Sean? Do you want to save them for me to come over there, or you want to ask them?
I have quite a few, so I can ask you one more before you come over.
Yeah, ask one more, and then I'll come over there to the conference room and answer all the questions. You get to see my face. All right, go ahead.
Yes, this one comes from a viewer on Periscope who says, Dr. Deuk, I notice a lot of variance in the reports from radiologists as well as the quality of MRIs that I've had in the last few years.
Yep.
Why is that?
You have really uncovered a really big issue. It's really near and dear to my heart. I have found the same thing. I started really practicing and understanding MRI, how to read them, back in residency, and I saw that different radiologists read the same MRI differently. And I was wondering, why is there so much variation? So you wouldn't believe some of the answers I've gotten. We're just about done. This is this is a very pain-sensitive area. So the reason is that radiologists it's just bias. There's no standard. And a lot of radiologists don't know how to find a herniation. Like, a lot of herniations that cause pain are small. And they look at that and they say, oh, it's small, so it can't be causing pain. So we'll just ignore it and leave it off the report. But it's wrong to do that. They really need to report every structural finding. They're really structural reporters. You know, they're not physiological reporters. An MRI scan is not a physiological study. It doesn't tell you where pain comes from. It only tells you if there are structural abnormalities. And these radiologists, I just think it's a lack of training, a lack of understanding. And all right, I'm going to say something. I hope there's no radiologists listening to me, but usually the radiologists are in medical school. Well, let's just say they're the ones that don't study that much. I'm sorry, it's true. But they're the ones that, you know, typically the ones I know, they like partying and they don't like taking care of patients. So they go to radiology, okay? I'm sorry, but I'm being honest with you guys. I've always told you I'll be honest. All right, we're done. Yeah, so they're not really the best students. They don't understand the disease that well, and they certainly don't treat disease. Radiologists don't treat disease. I treat disease every day. I treat back pain every day, neck pain every day. I understand it. But radiologists, they don't treat patients unless they get into interventional radiology where they do. But most radiologists just sit in a room and read MRI scans. So you're right. What you're observing is true, and it's not unique to you. It is a problem across the United States and the world. That's why I don't rely on radiologists to tell me what's wrong with the patient's spine. I figure it out myself. Basically, look at that disc material stuff there. Here's the thing. Most patients with horrible back pain, neck pain, thoracic pain from a disc injury, that disc herniation is small. Most of those people with pain from a disc injury, that injury is a small tear or a small herniation, okay? Most doctors will look at that MRI and say there's nothing wrong with that disc. They miss it. They miss it because they don't understand that the pathophysiology of the disease, it doesn't require a big herniation. What they're all looking for is a big herniation that's pushing on the nerve, okay? They're looking for, look, let's say Luis's arm is the nerve. Can you see this? Can you guys see the nerve?
Yes, we can.
So that's the nerve, right? Here's the back of the disc right here. So when a patient gets a tear, there's inflammation inside the disc, the annular tear, and that gets onto the nerve and irritates the nerve. That's why people get leg symptoms. But the radiologist, if they don't see something pushing on the nerve, crushing it, or the surgeons don't see something pushing on the nerve, crushing it, they say, oh, there's nothing really wrong with that disc. It's just a bulge. But that bulge is the cause. All right, we're going to show you the incision. The incision is right here. Can you all see that? 7 millimeters.
Yes, we can.
All right. The whole surgery was done with that. His pain will be gone for the rest of his life. I expect his leg pain to be gone as well when he wakes up. So we'll interview him in about an hour in recovery as he's leaving to go home. He's actually from Georgia. You know, we get a lot of patients from out of state. I have a Ray Tech off. This patient came from Georgia to get his back fixed here at Deuk Spine in Florida. We have patients that travel from around the world because we're the only ones that can fix their herniated disc that's causing pain, the back pain and neck pain. So people come here for endoscopic Deuk laser disc repair. Okay, I'm heading over and I'll answer some more questions. EBL 1 mil, no complications. This is the DLDR, left, L45, 5S1. Thank you everybody, great job. And Doc, if you want to talk about the next case, I'm going to sign off, I'll be right over there, okay? Well, hello. I'm Dr. Deuk Majin, and you've been watching our surgery live stream here at the Deuk Spine Institute in Melbourne, Florida, the Space Coast of Florida. We're rubbing shoulders with the likes of Elon Musk and his SpaceX program, and of course Jeff Bezos, my good buddy over at Amazon, who has his Blue Origin program just down the street here from our office. So this is really where the future of not only space travel but also spine surgery is. And we're doing surgeries here that no one else in the world is doing yet, but they will be. And the reason they will be is it's so safe and effective at eliminating back pain and neck pain. And nobody else has a surgery that has a 98% elimination of preoperative back and neck pain, as well as the safety profile of doing over 1,000 surgeries without a single complication to date. So we're very excited about the future of this technique that you're watching for the last surgery. As I said, the next surgery will be a more traditional type spine surgery. And the next surgery we're doing is going to be on the back of the neck for a patient who, if you can see the spine model here, how's that? Good? All right. So this patient, if you look at the cervical spine or the center of the neck where the spine is, there's a metal plate and screws that were put in by another surgeon, and those things did not hold, and they failed to fuse between the bones there. So I'm going to do a corrective surgery by going in the back and actually opening up the bones and pulling them out, and then you're going to see the spinal cord that was being crushed. We're going to unpinch the nerves as well that are coming out through the holes. I can't do laser surgery on this next patient because it just won't work, and it's not safe. I don't believe in doing surgeries that don't work. I've never done a surgery that doesn't work in my entire career. I just think it's unethical. So I always offer my patients the very best surgery for them. And probably about 95% of the time, it's going to be the Deuk laser disc repair to cure their back or neck pain. And maybe 5% of the time, it's going to be a more traditional decompression, realignment, and fusion with screws and rods. So if you have time, step in for the next surgery. We'll get started in about an hour, and it should be really neat. And there's some good anatomy. You're going to see things you'll never see anywhere else in the world. And the reason is because no other surgeon in the world shows you their surgeries like we do at Deuk Spine Institute. And the reason for that is normally there's a lot of mistakes being made, and they don't want a video record of that. Me, I'm very confident in my skills and ability. I've figured out every single second of the surgery. If you watch the surgery, every single second of the surgery is accounted for. I don't leave anything to chance. There's no, let's see what we're going to get when we get in there. There's no surprises. I already know everything ahead of time based on the physical exam, nerve test, CAT scan, x-ray, and MRI. So I don't believe surgeons should go into a patient and be surprised by what they find, except, I mean, in 26 years, I think I was surprised once or twice in about maybe 10,000 surgeries. Okay, so surgeons should really have a very good idea. They should know exactly what's going to happen when they get in the operating room with the patient. There shouldn't be anything left to chance. You should have a plan. It should be well organized, and it should be appropriate for that patient and everything going on with them, whether it's deformity or stenosis or just pain. And that's how we approach our patients at Deuk Spine Institute. Okay? All right, let's take our first question.
This first question comes from YouTube. A viewer is wondering, do you just remove the protruding part of the disc herniation instead of taking out the whole disc? What else do you do that makes the surgery unique?
Yeah, so great question from one of our viewers on YouTube. So let me talk about what makes the Deuk laser disc repair unique, okay? First of all, I've got some great news. We're going to be releasing a series of animations on our website and on our Deuk Spine Institute app, which you can download for free on your iPhone or Android platform. The Deuk Spine Institute app has a lot of really useful contemporary information. We're getting ready to do another update on the app. We've been working on it now for a couple of weeks, and we're going to be releasing an update with more information and making it more user-friendly and a better experience. But that said, we also are working on animations, animations are great educational tools, and the animation's going to show you the difference between the Deuk laser disc repair and all other types of spine surgery. And you're going to see, probably for the first time in your lives, just how damaging other types of spine surgery are. Surgeries like fusions, surgeries like artificial discs, surgeries like microdiscectomies, laminectomies, fusions, all of those types of surgeries come with a huge cost, And the cost is not necessarily money, even though it can be, they're very expensive, but the cost is in your body. You're going to pay the price. So it's interesting that you asked this question, and I was watching The Witcher. Anybody watch The Witcher on Netflix? Amazing. It's a really good show. They only did season 1 so far, but they're going to release season 2. Anyway, The Witcher, I'm normally not into that kind of stuff, but it's really well done. So if you know what I'm talking about, there's a scene in, I think, episode 3 where one of the main characters, she wants to undergo a procedure to become beautiful. Jessica, if you guys know who I'm talking about. And of course, there's a price she has to pay for that, and so I won't spoil it, but you can watch The Witcher season 1, episode 3 or 4, where Jessica undergoes a transformation. Okay? So, Jessica has to give up something in order to undergo her transformation. And what she has to give up is an absolutely horrible price to pay. But she gets what she wants in the end. Spine surgery shouldn't be a situation where people have to give up things from their body, taking on damage and loss of function in order to gain some relief of pain. Okay? And that's what spine surgery has traditionally been. It's been the surgeon comes in and does something damaging to you, like a fusion with screws and rods where you lose the movement of your spine forever. The rest of your life, you can't move those bones. Okay? So you're assuming that damage in exchange for hopefully getting some pain relief. And the reality is that most spine surgeons, they'll fuse your spine, but you will be in more pain afterwards because they don't do the surgery properly. Okay? So in the movie The Witcher, or the program The Witcher, I'll tell you, Jessica has to give up her uterus so she can never have babies, her uterus and ovaries. Okay? I didn't do the series, all right? But I'm just telling you. So she's giving up the ability to procreate and make children and have a family. She gives that up in order to get rid of a horrible deformity that she was born with. So the point I'm trying to make is she didn't choose the deformity. She didn't choose to have a twisted spine and face, but the surgeon could fix it for her, but she had to give up her uterus and ovaries. That's kind of like how modern day spine surgery is. Honestly, it's just like that. Why? Because you're giving up your body, your spine. You're taking on a big incision in your back, which you don't need. You're getting all the scar tissue below the incision. You can't see, but it's there. And the surgeon is just pulling out ligaments and bone. And you're going to see this, by the way, in the next surgery I do today, the posterior cervical laminectomy and fusion. Big incision, peeling the muscles off the spine, removing bones and ligament, all to treat pain and pinched nerves. I can do that, treating the pain and pinched nerves, and cure it better than any fusion using the Deuk laser disc repair. So here's how. Let's take this model here, and you can see the red thing. The red thing there is a herniated disc, okay? That's the disc right here, and there's a piece that's coming out of the center, the jelly. And it's getting the nerve irritated. The nerve goes down the leg, causes leg pain when it's irritated here. This herniation and tear is what's causing the back pain. So what's unique about my surgery is that with the Deuk laser disc repair, we don't make a big incision. We don't peel the muscle off the spine like they do in microdiscectomy or fusion. We don't take this bone and drill all the bone away. You're going to see that on the animation when it's released, to get down and pick pieces of the herniation out. Okay? What I do is I actually come from the side and I go through a natural opening in the spine where the herniation is. It's called transforaminal. That's why my incision's not in the middle, it's off to the side. And then when I get that disc herniation, okay, there's the part that's protruding right there. It looks like a little bump. I take that out, but I also take this part out, which all the other surgeons leave. That's inside the disc. The annulus fibrosus. It's a tear. It's a damaged part of the disc that's causing all the back pain. This is what I remove right there. So I remove the core of the tear all the way to the cap. What do other surgeons do? If they do a fusion, they take the entire disc out and they put a cage in there or a piece of plastic or cadaver bone. So you're losing your whole disc. What I'm taking out, what you're seeing I'm taking out, is nothing normal. None of what I took out today with the laser was normal disc. It's all damaged and it needed to be repaired. Think about your house. If you have your house and there's a fire that goes on in the kitchen and burns your kitchen down, but the rest of the house is okay, other surgeons are taking the whole house, demolishing it. I'm going in and just fixing the kitchen, getting rid of all that debris, the burnt wood, the burnt plastic, all the damaged parts of your home, cleaning it out, getting rid of it, and leaving the rest of your home there, okay? Not touching it. And over time, we're rebuilding your kitchen. Does that make sense? So other surgeons will destroy the whole house, destroy the whole disc. However, with the Deuk laser disc repair, we're just removing the damaged parts, okay? So we're not taking anything normal out. Good question. I hope I answered it. Next.
That was actually our last question.
Last
The other
question.
ones are just requests for information, which I'm providing in the chat right now.
All right. Well, if you want to get a quick question in, type it up now. I'm happy to answer it. No question is a stupid question. This is an opportunity to learn more about the spine. And once again, we'll be back here broadcasting in an hour with our posterior cervical laminectomy and instrumented fusion. So pretty cool case to watch, and it's only about an hour and a half long.